Hey,
I tried to spruce up my bedroom with some books up here to make it look more professional. How'd I do?
I think it's great. It's that.
I don't live in a very big, I live in Columbus, but we live in one of the like really central core neighborhoods. And so like my house is over 100 years old and we're lucky we have, you know, enough bedrooms for one for each of our children. So there is no office space in my house.
Yeah, I can relate. Sans the children, but yeah, we're in my partner and I are in a small, Queens apartment, actually down the street from Craig. So yeah, it's
Oh, are you? That's funny.
yeah. So I have the bedroom, and my wife has like the main room as our offices because she's working from home as well. But yeah, it works.
Yeah, I mean, it's a challenge for everybody. There's no doubt about it. And it's not going to be over anytime soon. So
Uh, yeah,
I
you're
know.
saying that then.
I know sometimes I should just not say anything, right?
I was just hoping maybe next academic year will be a bit more normal, but
Well, it's funny because I have a lot of friends who are like, how long is this going to go on? Like they ask me these questions all the time. And I'm like, guys, this is not going to be over for a while. Like, I hate to tell you that. I know it's the bearer of bad news, but this is not ending anytime soon.
yeah, I mean, at least a lot of people got normalized to it, I guess.
Yeah, I mean, I do think there is that, right? Like we're slowly figuring out how to live in this new world that we have. I'm trying to figure out what the best layout for my camera would be.
Oh, totally. So I was just going to do like a really quick, intro of your name and affiliation, but I can do more if you want, at the start, whatever. I can read your faculty bio, whatever you think is best.
Yeah, if you just want to do something quick, I can also just introduce myself. I mean, I can, give a smidge about my background if that would be easiest.
Yeah, I think that's good. The more you're talking, the better.
So in terms of, sorry, I keep getting emails about voting. In terms of timing, so we have an hour. I've only really prepared about 30 some few minutes, which I was hoping was good because I assume you want to invite questions.
Definitely, yeah, that's perfect.
Okay, great.
And to be honest,
I was throwing this all together and I'm like, there's so much we don't know, right? And there's so much that hasn't been done yet that in reality, like anything I can present can't take up more than about, so. Yeah, okay, good. Then it sounds like I've prepared for it correctly. So that's good.
Yeah. I was gonna start a few minutes after 4 anyways, just given the nature of these things. I start more like 4 or 5 anyways. And if you talk for 30 minutes and we have 20 minutes of questions, I think that's perfect.
Great, good.
So yeah, hopefully it's been relatively smooth. Obviously my first time doing this, but
yeah, so do you have like some crazy control panel where you can like pop into different rooms and stuff?
No, I just have 2 monitors and I've been the tech person. He's been he said he has all like 2 or 3 going at once, so he's holding it down. And yeah, it's
he an AAG person or is he Hofstra?
No, he's just he's AAG, but he just hired him from outside. Like he's not.
Wow.
Yeah. So.
Well, good. I mean, I'm glad they sort of took appropriate steps to figure it out because I think this is going to be our reality for a while now.
I agree. I mean, some people on our board just said we got to cancel it, and I said we got to give it a shot because it's not. Yeah, exactly. It's not. There's no indication that this is a one-time thing necessarily.
I know. Yeah, I'm kind of interested to see what they do with AAG in April. Like, I just don't know how I don't know how you can have people traveling from all over the United States to go. I mean, put aside meeting together in rooms. Like, I do believe that there's ways of doing that somewhat safely, as long as we don't pack rooms full of people. but having people travel from all over the United States or potentially all over the world to come someplace, it's not tenable. Like you just can't do that right now.
I don't understand there's no, like, obviously we like to be in person and partying and everything, but even that's not a possibility. So what's the gain of going in person when you can do it on Zoom?
Yeah, aside from not having to sit in front of Zoom for.
I totally, totally sympathetic to, but.
I mean, I can't even tell you. There are days when I start on Zoom at 8:30 in the morning and I don't end until 5:30 at night. You know, it's funny. I have a really good friend who's not affiliated with the university. She's a friend of mine through my daughter, and she said back in like January we were sitting around, having a beer, and she says, Liz, it looks like this is going to be your Olympic year. And we laughed, and I said, yeah, I mean, this is what I've been training for my whole career, right? The global pandemic has arrived. We've been predicting it. And she texted me like last night, and she's like, I was just thinking back to that conversation we had in like February. And she says, it's not so funny anymore. I'm really sorry.
Yeah, was it in February when you like first realized that this was going to be a legitimate global pandemic?
So I think I knew in December that it was going to, because that was when we heard that that it had sort of been identified in Wuhan and it sort of started to spread. But I think by the end of January, I had a pretty good sense that this was going to go south really, really quickly. As soon as it hit Paris, when it hit Paris, that was it. I knew we were in trouble. And it's just so interesting because my husband's actually a mathematical epidemiologist. He does math modeling of disease. I mean, now he's a math teacher in high school, but that's what his PhD's in. And we were talking in end of February, beginning of March, when our state was trying to make the decision about whether or not to close schools. And he went in and he said to all his colleagues, he's like, look, guys, they're going to shut down schools and we're not going to be back for the whole year. So anything you want, you should take home. And everybody's like, oh, you're full of shit. They're like, what are you talking about? That's not going to happen, right? And we were, lo and behold, and his school district still isn't back in person. So, but that's not new for you guys. I mean, New York City has been struggling with this too.
Yeah, I think, not being an expert, but just being a scientist, we're ahead of the curve here, is because it happened here so much more quickly. And I know by February, it's like I was stocking up a bit. We were stocking up a bit on like hand sanitizer, just in case, not hoarding, but just getting a little bit. And I know for me personally, it was like right at the end of February, maybe the first few days of March, when it started coming. And then I forget who said it, but some authority said like we've given up on contact tracing. As soon as I heard that, I knew like that was it.
Yeah.
So
yeah,
scary.
exactly right. Like the moment you give up on something like one of the core public health strategies that we have to deal with this, that's the moment you know how bad it actually is, right?
But what's interesting, and I guess obviously you have the expertise, but we'd heard sometimes about, I don't know, the swine flu or other things possibly becoming a pandemic. So what was it about this that really tipped you off to make you think this was going to be more significant?
So for me, it was so all of this it was the Diamond Princess. Do you remember the cruise ship? Mm-hmm. That's actually what tipped it off to me. So it's really hard, this number that everybody throws away, are not, right? Like the infectivity rate. That's actually really hard to estimate. It's a really big question about how do we even calculate what that number is, how many people you get sick if you get sick, And the Diamond Princess, when they did the initial analysis on that, like the rate of infectivity was higher than anything we've seen in modern times aside from like measles. And the moment that I saw that in that closed environment that's really controlled, right, was the moment I knew that we were in real trouble. Actually, in some of the really early stuff that came out about prisons in the United States. So Ohio had one of those massive prison outbreaks. Like we had 1,000 inmates get sick in one of our jails in Marion County. And again, right, if you control the environment and the only thing that's different about people's, actions in a space is that they're breathing on one another. You really get a sense of how quickly and easily something can spread. And the prisons are just astounding across the United States.
Wow.
Yeah. We've been doing it. We looked at a lot at that in March, the prison outbreaks in Ohio. So
Leave it to a cruise ship to somehow be in the middle of it, though. I remember
don't you know it?
it's a joke amongst us, like meteorologists and hazard communicators as well, because there's this one cruise ship that always seems to like go into hurricanes by accident. So it always seems like their public safety is a big shortcoming in many different ways, I guess.
Yeah, I wouldn't go on a cruise ship to save my life. Well, maybe to save my life, but like between like norovirus and other things that you pick up, as well as now COVID, I just can't imagine. Doesn't seem like the kind of vacation I want to take.
You'd think this would be detrimental, even if we do normalize more in a few years or something for cruises.
Exactly. So can I share my screen? Oh, you have to enable my sharing.
Yeah, sorry, I'm gonna make you a co-host.
Okay.
Just so in case something happens, and then you should have you should have the sharing options. And if for some reason my network like corrupts and I go out, you'll have control of the meeting.
Yeah, we had to up our internet game too here.
Yeah.
Big time.
And I suppose if you have some children as well, you must have a lot of competing devices.
We do. I have 2 children homeschooling, my husband and myself, and we just, the first couple months we dropped all the time. It was awful. Like couldn't get anything done. And then we rolled out the big bucks.
Just a new mandatory thing now.
It is, totally is. Another avenue for inequality, actually.
And it's really, unfortunate. So my courses, we have international students, and obviously, it seems that some of those places just, the network isn't as good, and it's a definite issue. And I wish there was a solution, but I don't know right now. So yeah, certainly, I'm sure people start joining at 4 a few minutes after. So definitely wait till like 4:05 to get started in earnest. Hopefully people aren't getting zoomed out already.
No, I know. It's hard.
Right, those of you who are joining, thanks for coming in. We'll wait till probably about 4:05 to get started, just to allow people more time to get joined in. And maybe people are taking a quick break from Zoom here with good reason. So we'll wait for a few minutes. For those of you just joining us, we're gonna wait till about 4:05 4:05 get started. Figure people might be taking a quick Zoom break. So we'll allow a few minutes for people to join in and get started with Dr. Elisabeth Root's keynote. All right, we'll get started in just another minute or two. Just to allow people a few more seconds to join. All right, well, it's 4:05, so let's go ahead and get started. So thank you again, everyone, for continuing to join in the conference. I know Zoom can get a bit tiring, and we're already on our fourth session of the day. So thanks again, everyone, for continuing to participate. So we're really lucky this year in our virtual Middle States AAG conference to have not one, but two plenary speakers. And our first speaker here this afternoon, we are really, really fortunate to have one of the leading health geography experts. So we have Dr. Elisabeth Root. Dr. Root is a professor in the Department of Geography at Ohio State University, and her research interests include human health and disease ecology, global public health, program evaluation, spatial statistics, and GIS. So Dr. Root will be speaking to us today about a little bit more about the COVID-19 outbreak and related health geographies topics. And after she finishes speaking, there'll be plenty of time for questions from the audience. So once she concludes, you can feel free to type in questions in the chat box, which we'll be monitoring, or also coming off mute and asking a question verbally as well. So without further ado, please welcome our keynote speaker, Dr. Elisabeth Root.
Thank you, Jace. Thank you so much for inviting me to speak with everybody this afternoon, and for forging forward and having your conference, your regional conference, despite the challenges that COVID has presented to all of us. So as Jace said, I am a professor in geography and epidemiology at Ohio State University. And I've never really been anything other than a subdisciplinary health geography. And so Jace and I were joking prior to me starting this, saying that this is something that I've been studying for most of my career, and always hoping that what we as health geographers had predicted, that some global pandemic was quite likely during our our lifetime, actually came to fruition. And so here we are, and it's vastly more complicated than I think I ever anticipated in all of the years that I've been doing research. So that being said, what I'd like to do today is discuss my sort of take on the geographies of COVID-19 in my experience over the last 8 months. I've not just sort of been studying what's going on academically, but I've actually been embedded at the Ohio Department of Health for the last 8 months, assisting them with data and surveillance activities. And so I've had a lot of time to think about this, and think about practically what I know and what I've learned is turned into or is understood by public health. So I'm going to start sort of way back. Hold on a sec. There we go. I'm going to start way back. In 1963, there was a respected physician and anthropologist named T. Aidan Cockburn, and he wrote a book called The Evolution and Eradication of Infectious Disease. And in this, he said, we can look forward with confidence to a considerable degree of freedom from infectious disease at a time not too far in the future. Indeed, it seems reasonable to anticipate that within some measurable time, all major infections will have disappeared. His comments were bolstered by incredible medical advances, such as antibiotics and vaccines, and public health measures like sanitation and water purification, as well as a green revolution which improved nutrition around the world. My grandfather, Dr. Harry Dowling, was actually among some of the first investigators to evaluate sulfa drugs and penicillin in the treatment of pneumococcal infection. And as a child, I actually remember taking long walks with my grandfather, listening to his stories of optimism and excitement at these discoveries. There was really a sense in the medical profession that we were at a turning point. 5 years later, the US Surgeon General noted that it might be possible with interventions such as antimicrobials and vaccines to close the book on infectious disease and actually shift many of our public health resources towards chronic diseases. Ironically, I learned last year that this quote was never actually said by Dr. Stewart and has been erroneously repeated through the ages. So I'm going to do my best to stop that now. But its perpetuation as a quote is indicative of a general feeling of optimism during the middle of the century. But as we've seen, even public health leaders can make mistakes. And actually, about the time that this quote was attributed to Dr. Stewart, there were scattered reports about a really interesting wasting disease among Africans that was noticed by missionaries there. We now realize that these were the earliest cases of a newly emerging infectious disease, HIV. And today, HIV and AIDS and other infectious diseases continue to pose a substantial threat throughout the world. These statements taken together seem almost comical today in the face of our global COVID-19 pandemic. A newly emerging disease is technically a disease that has never been recognized before. COVID-19 is actually a newly emerging disease, as was its predecessor SARS and HIV before that. Most emerging infectious diseases are zoonotic in origin, meaning that they come from animal populations and somehow make a jump into human populations. A study published in Nature in 2008, this map is from that, looked at factors such as land use, wildlife diversity, economic development, and population density to develop a series of risk maps. These maps suggest that emerging disease hotspots are more concentrated in the lower latitude developing countries, and you can see that reflected on the maps here. Each panel represents the risk index, with red being the highest risk, for zoonotic pathogen emergence. The top panel in the left, panel A, shows pathogens from wildlife, which is exactly what happened with COVID-19. This same study actually showed that there are hotspots of emergence that we know about around the world. You can see a cluster in the Northeast United States, and this is the emergence of Lyme disease and West Nile virus. The cluster in Northern Europe is related to the evolution of antibiotic-resistant TB as well as MRSA. These hotspots actually don't seem to align particularly well with the risk maps that I showed you on the prior slide. The challenge is that the majority of our scientific resources focus on places from where the next important emerging pathogen is least likely to originate. There is a need to reallocate our resources around the world for smart surveillance to different emerging disease hotspots in the lower latitudes, such as tropical Africa and Asia, so that we can identify early clusters of potentially new emerging infectious diseases. The idea, of course, would be to catch the emergence of a disease such as COVID-19 before they actually have time to spread around the world. Multiple factors, including globalization, economic development, and land use, human demographics and behavior, political conflict, and migration, contribute to the emergence and reemergence of infectious diseases. Many of these processes, as we all know, are studied by geographers using theory, tools, and methods that span the breadth of our discipline. And almost all of these factors reflect in some measure the encroachment of human civilization into the environment. We humans live in a delicate balance with the natural world, a dynamic equilibrium. And there is an ever-present tension between the two. And if we perturb this balance, the microbes that cause disease almost always figure out a way to counterbalance that effect. Lyme disease emerged as we developed land near forests, and changes in social structure and human behavior contributed to the emergence of HIV. In my field, Jacques May, who is considered by many to be one of the fathers of modern medical geography, theorized in a book called The Ecology of Human Disease, the existence of what he called the silent zone. He defined this as a geographic area where certain environmental conditions that simultaneously support vectors, reservoir, and an agent can lead to disease. For those folks not familiar with this terminology, vectors are things like mosquitoes that can carry a disease. A reservoir is an animal population that hosts the disease in the absence of a human population, and the agent is the microbe that causes the disease. Of course, not all zoonotic diseases require a vector, but you get the idea. Many may hypothesize that diseases had something called a natural nidus. It's a term that was borrowed from a team of Russian geographers who were the first to study the bubonic plague. And that's an area where these three different factors coexist naturally. Without human encroachment, this is actually what he called the silent zone, because the disease is contained in this small area. When humans build roads and clear land and begin to settle and build houses and towns, suddenly the disease has a new host. And then this silent zone becomes loud and our diseases emerge. With that introduction into the fairly large and extensive field of disease ecology, let's turn to COVID-19 and consider the drivers of its emergence. We still have a tremendous amount to learn about COVID-19. Let's not make any mistakes about that. But mounting scientific evidence helps us understand just a bit about the origins of our pandemic. Animal markets are implicated in the jump of SARS-CoV-2, which is the virus that causes COVID, to humans. Investigations in Wuhan traced one of the initial clusters to a seafood market, which was also known for wildlife trading. We do not know yet if the virus jumped directly from a bat or through some intermediate host in that market. It actually took us decades of genetic research to understand the origins of HIV, and I suspect we'll continue to grapple with SARS-CoV-2 for years to come. COVID-19 emerged at a time when people in China traveled to visit family and friends to celebrate the Chinese New Year. So by the time officials in Wuhan understood the extent of the disease, COVID-19 had been transported around the country, and it was difficult to control despite the nearly total lockdown of the city of Wuhan. A very recent study, it's still under peer review, examined the concordance of multiple population and environmental drivers in bat habitats. Bats are actually a known reservoir for a range of coronaviruses. They found a very high level of overlap between livestock density, forest fragmentation, and human settlement with traditional bat habitat in China. A perfect storm of factors ripe for the emergence of a new coronavirus. Though I have to admit, I'm not a fan of the cartography and the maps provided in the research paper. They are somewhat compelling in the science. What these panels show is the stretch of land from the Iberian Peninsula on the left to Indonesia and the east coast of Australia on the right. If you didn't get that immediately, don't worry, I didn't either when I looked at it. And this is actually where a certain species of bat lives that is known to carry coronaviruses like COVID. They then mapped out the different land use patterns that lead to human-animal interactions to see if those two things overlapped. And then they identified sort of hotspots of these. Further analysis revealed that China and a much smaller region in Bangladesh and Indonesia sort of had a hotspot with all of these factors clustering together. It's a good spatial analysis. The red spots on this map indicate areas where those multiple factors cluster in space. And there's a clear relationship between the red cluster in China and the yellow dots, which indicate the bat's habitat. Certainly, this is not proof that these types of land use change and population factors led to the emergence of COVID from bats in China. But it's very strong circumstantial evidence and shows the power of geographic research and science to help us understand the emergence of this disease. Though COVID-19 was initially reported in Wuhan, China, it very quickly spread throughout the world. As I mentioned earlier, the Chinese New Year led to significant population movement from Wuhan to other locations around China, both urban and rural, and it spread the disease to Beijing, Shanghai, Singapore, Bangkok, Hong Kong, and all places in between. Paris, it seems, and perhaps Frankfurt were the early introductions into Europe, and Los Angeles and Chicago were the introductions into the United States. This is an example of how widespread transnational population movement, which is something that we as geographers study, helped to speed the spread of this disease around the world. Pandemics, though, rarely affect all people in a uniform way. And the questions that I am particularly interested in are not so much tied up in the technicalities of COVID-19's emergence. I do find it fascinating how the story of COVID-19 supports many of the theories of disease emergence that I have studied throughout my career. But my real interests lie in how inequality as a broad and inclusive concept affects first the emergence and then the spread of the disease. Emergence is caused by multiscalar inequalities, and newly emerged diseases have unequal population impacts. The first of these problems fascinates me from an intellectual sense, but it is the second that most of my personal research addresses. But first, I would like to talk about that first one a little bit. The process leading to the emergence of COVID are bound up in unequal distribution of the world's food resources. Meeting the United Nations Sustainable Development Goal to eradicate hunger for the expanding population will necessitate a large increase in food supplies, with major changes to agricultural production and distribution systems. And despite large and growing inequalities across the world, the global population is on average expected to become richer. And historically, with greater affluence has come greater consumption of food products, in particular more animal-sourced food, both of which further increase food demand and the requirements of agricultural expansion and intensification. The past 50 years has seen a global movement toward commodification of land and elongated global food supply chains. International demand for agricultural commodities has resulted in domestic, private, and foreign participation in agricultural industries in many developing countries. What began with the privatization of common lands has transitioned to consolidation of land ownership for the wealthiest private landowners. In the United States, for example, the 100 largest landowners have holdings of 40 million acres, which is equivalent to the entirety of New England, minus Vermont. Moreover, a large transnational corporation engaged in contract farming and have recently begun to buy land outright in what are called land grabs. This movement towards privatization of global food production has resulted in massive land use change. Deforestation, monoculturing and cash cropping, increased use of chemical inputs like fertilizers and pesticides, loss of small farms, and the subsequent increase in large agribusiness. These changes have preyed upon and led to significant social and economic inequalities. Contract farming practices are often exploitive. Traditional rural systems of social support and cohesion are damaged. Traditional lands and family farms are lost. And this forces migration to either urban areas or adds to deforestation as households clear more land. Changes in rural livelihoods often lead to food insecurity, which exacerbates poverty. There are books and dissertations written about this topic by our colleagues from nearly every subdiscipline in geography, and I can hardly do it justice here. And this is really not the point of my talk this evening, but I bring it up to make 2 points. First, emergence is caused by inequality and asymmetric systems of power that operate at multiple scales. The globalization of agricultural production and privatization and commodification of land is a global process with very local impacts. Second, the expansion and intensification of agriculture are disproportionately occurring in tropical developing countries, where 75% of deaths are still attributed to infectious disease, where the risk of disease emergence is the greatest, and where disease surveillance and access to healthcare are most limited. This is precisely the global change that in land use that's driven by and leading to social and economic inequalities that have led us to this moment, right? This COVID-19 global pandemic moment. So turning to the United States, geographic differences in the number of COVID-19 cases and deaths likely reflect a combination of area level, epidemiologic, and population level factors. Some of the geography of COVID is directly related to the timing of COVID-19 introductions and subsequent community mitigation measures. We all watched and you experienced in horror as the virus brought New York City to its knees. I have a former student who works for the New York City Department of Health, and she texted me at the end of March. She said, "It's incredibly scary here. I've made myself stop reading the New York Times before bed because I haven't been sleeping. Health systems collapse is an imminent conversation in the New York City Department of Health unless something really changes." Our other communities across the United States soon joined: Chicago, Los Angeles, Detroit. These early communities were unprepared and the virus took a very heavy toll. The geography of COVID is also related to population density and population mixing. Highly dense areas increase the number of people you come in contact with, which naturally increases transmission from person to person. We know that this is doubly true for COVID because it's spread through an airborne transmission route. So large cities were the first to be hit, and they are well reflected on this map. But what about the South and the upper Midwest? Why do we see these clusters there? Communities with more elderly, of course, were also hard hit. Early in the epidemic, nursing homes served as the single largest source of COVID death in the United States. We also know severe illness and mortality were highest among the 65 and over population. The aging of the population in the Midwest and the concentrations of elderly in the southern states certainly contributed to the patterns of COVID we see today. At the same time, we spent sort of the past several decades hearing about the obesity epidemic and the concomitant increase in diabetes, heart disease, and other chronic health conditions. Some of my early research explored relationships between the built environment and physical activity and obesity. And many of my geography colleagues continue this line of research today. As this very cool bivariate map, so this is a good map as compared to the bad maps we saw earlier, the Midwest, Appalachia, and Southeast states have the highest rates of obesity and diabetes combined. Early studies revealed that certain chronic conditions such as COPD, obesity, and diabetes placed people at much higher risk of severe COVID disease. These conditions are also concentrated in low-income communities and are poorly managed because of a lack of affordable healthcare. It's no wonder that these regions emerged as COVID hotspots in the US. These were the areas where an already serious chronic disease epidemic and the pandemic collided. We know that the social and structural inequalities impact obesity and other chronic diseases, but they also clearly have a direct impact on COVID-19 as well. Socioeconomic inequalities can impact exposure risk and people's ability to seek care once they do get sick. African Americans and other minority communities relative to whites are more likely to live in neighborhoods with a lack of healthy food options, green spaces, recreational facilities, and safety. Low-income individuals represent about 1/4 of all public transit users and are less likely to have equitable healthcare access, meaning hospitals are further away and pharmacies are subpar. Staying home during quarantine is a privilege, one that low-wage workers and those with precarious employment do not enjoy. These pre-existing social vulnerabilities only worsened during the public health emergency. There are so many ways in which social and structural determinants of health can, are, and will continue to impact populations across the United States. I would say that access to health services is perhaps one of the easiest examples to use. Research has shown us that emergency department visits declined by 42% during the early COVID-19 pandemic, and the number of outpatient visits declined nearly 60% by early April. That's actually astounding. And the graph on the left is from the CDC and shows the decline in ED visits. That's 50% reduction in people seeking help for care or care for health. Since that time, a rebound has occurred, but the number of visits is still roughly 1/3 lower than it was before the pandemic. And the rebound has been smaller among school-aged children, especially low-income and underinsured children. But as in-person visits dropped, telehealth visits actually increased very rapidly in a way that's been unprecedented in the health community. But I would say that numbers like this mask a much larger problem with accessing care. US states, mostly in the South and in the Plains, which have been hardest hit by COVID, have refused to accept Affordable Care Act Medicaid expansion funding. And this leaves millions of the poorest and sickest Americans without access to health care. People with COVID in those states will have poor access to the kind of emergency and intensive care that they will need, and is partially reflective of the death rates and the COVID rates we see there today. The telehealth example also provides another look into structural inequalities. With more than 3 billion people worldwide in isolation, the status of our digital spaces is switching from an amenity to a necessity, as they become not only the main way to access information and services, but also one of the only remaining places for economic, educational, and our leisure activities. However, not all of us are equal in terms of access to networks or connected devices, or when it comes to the skills that are required to navigate these computerized spaces. Low-income households in particular have less access to broadband internet and high-speed data plans. Digital inequalities were already existing, yet the COVID-19 crisis has exacerbated them dramatically. We also know that across the country, deaths due to COVID-19 are disproportionately high among African Americans compared to the population overall. This chart is from the CDC and reports that deaths due to COVID are 2 times higher in African Americans than whites, and hospitalizations among African Americans and Hispanics is over 4 times greater. And this is all done with really poor data. We have really poor data on race in the COVID epidemic. Early in the epidemic, actually, a group of lawmakers led by Senator Elisabeth Warren called on the federal government to change how they were collecting data. In a letter to Health and Human Services Secretary Alex Azar, the lawmakers wrote, and I quote, "It is critical that the federal government make a concerted effort to account for existing racial disparities in healthcare access and how persistent inequalities may exacerbate these disparities in the weeks and months to come. We urge HHS to work with states, localities, and private labs to better collect data on health disparities as we continue to respond to this pandemic." I've looked into this in Ohio, and in Ohio, 11% of our COVID records have no race recorded at all. and another 7% are simply tagged as other. This means that for nearly 20% of the COVID positive population in my state, I have no information on potential inequalities. Part of the disproportionate impact of the COVID-19 pandemic on the communities of color have been structural factors that prevent those communities from practicing social distancing. Minority populations in the US disproportionately make up our essential workers, such as retail, grocery workers, public transit employees, and healthcare workers, and custodial staff. These frontline workers, disproportionately Black and Brown, are also typically a part of residentially segregated communities. The negative consequences of health disparities for people who live in rural areas in the US were already a problem before the pandemic as well. Poor white communities, especially in rural Appalachia, have been badly hit by the opioid crisis. Undocumented Latino communities working in rural industries such as farming, poultry, and meat production often have no health insurance. Access to healthcare is limited, and underemployment in rural communities typically means no health insurance. These are also some of the occupations that we know were really hard hit by early phases of the COVID pandemic, in particular the meat production and the poultry plants. It's interesting to note in Ohio that rural communities have the second highest rate of overall COVID infection, second only to the large urban centers of the state. So the map on the left shows the rural urban commuting codes from the USDA, and they're done by census tract. And you can see the urban areas. We've got the three C's, Cleveland, Columbus, and Cincinnati, in a diagonal going from north to south. And then we have a few other, Toledo and Dayton around here. But we have a lot of what would be considered small city and rural town regions, which are by and large quite rural if you drive through them. It's interesting to note that with the high population density and significant population mixing, we sort of would expect urban areas to be COVID hotspots. And indeed they were. There's the highest rates by far, as you can see, in the urban centers of our state. But the high rates in rural areas is somewhat surprising, and it hints at other structural and social processes that are driving COVID in these communities, and ones that we've clearly not addressed well in the state. Here we see what are called the epi curves for the COVID-19 in urban and rural communities in Ohio. Epi curves show the number or rate of new cases a day and are used by epidemiologists to monitor the spread of disease. I've linked the Ohio data to census tracts and assigned rural urban commuting codes to the data. Large urban cities are represented in blue and rural areas are in orange and red. There's two things to note here. The large urban areas in the state peaked first, followed by peaks in the rural and smaller towns later. It's a hallmark of disease diffusion pattern that I actually teach in many of the classes that I teach. Urban areas seem to follow a more boom and bust dynamic, with large peaks vacillating over time, while rural communities have seen a slower but steady increase in cases over time. Currently, the highest rates of infection are in Ohio's rural communities. We aren't 100% sure of why that's happening. We do know that mask wearing is much less in our rural areas, and people in these politically conservative areas of the state are less likely to adhere to restrictions in large gatherings. In addition, rural communities across Ohio opened schools full time, 5 days a week at the beginning of September, and most of our urban areas did not. I believe we are seeing the impact of that decision now. So I've established a deep and significant racial inequality and differences in COVID-19 across the rural-urban continuum. The other thing we've been looking at in Ohio is the overlap between COVID and socioeconomically vulnerable communities. Over the past 2 years, I've worked closely with the Ohio Departments of Health and Medicaid to develop the Ohio Vulnerability Index. It's a composite area-based measure of neighborhood socioeconomic and structural conditions. It uses 7 domains in the social determinants of health: transportation, education, employment, housing, crime, health, and environment. And it develops census tract level estimates of socioeconomic vulnerability. Here you see a map of the Ohio Vulnerability Index, highlighting the disadvantage in the rural Appalachia and in the urban cores of our cities. The red outlines indicate the census tracts with the highest COVID case rates in the state. To me, when I look at this, there seems to be an overlap in cities such as Cleveland in the north and Columbus on the bottom, though there's no clear pattern in the rural areas at all. But when you link COVID cases to the socioeconomic vulnerability index and look at the trends, there's really not much difference here. During the peak in July, cases seemed a bit higher overall in highly vulnerable communities, that's the red line, compared to low vulnerability communities, which is the blue line. But this trend reverses by the end of the summer, and now the trend lines look to be nearly identical. But when you think about it, socioeconomic vulnerability looks very different in rural and urban communities. Here I show the intersection of rurality and socioeconomic disadvantage. And what we see here is that trends are reversed between urban and rural communities. The first three sets of bars show the rate of COVID in rural and small urban areas. Here we see the most vulnerable population in red have the lowest rates of COVID, where the most advantaged, and that's blue and green, have the highest. In our urban centers, we see quite the opposite. Our most vulnerable populations have the highest rates of COVID. These data suggest that right now, rural privileged populations appear to be driving the epidemic in Ohio. Another thing I'm really interested in is whether these types of relationships that we've just explored, race, rurality, poverty, are consistent across space. In April, at the end of the semester at Ohio State University, I was struggling to find a way to connect with my students, as we all were. We had been switched to distance learning, and I was teaching an intermediate spatial statistics class, which is really hard to do online. For the last homework assignment of the semester, I decided to create a community level data set, a county level data set of COVID cases and deaths. And I tacked on a bunch of socioeconomic and demographic and health variables. I told my students there wasn't one right answer to the homework. I just wanted them to explore the data and report what relationships they could find. It was probably one of my most successful teaching moments, especially in a statistics class. The students were engaged. They felt like they were doing something meaningful. And in fact, a group of them decided to write up their project for a blog on our department's website. I was a very proud mama hen at that moment. And I've actually put that blog up on the slide right here. As I prepared this talk last week, I decided to go back and redo that analysis myself. What I'd instructed the class to do was use a technique called geographically weighted regression. GWR is a method that allows us to explore something called spatial non-stationarity. Essentially, one of the reasons that we see those spatial patterns of COVID-19 might be because of varying socioeconomic conditions, demographics, and health environments actually lead to a situation in which the relationship between COVID and those factors isn't consistent over space. It actually changes. So I developed a model that attempted to predict COVID-19 as a function of race and poverty and rurality, among other factors. And then I mapped these across the United States. So I'll show you what I did, and keep in mind that my students were all doing this too. So poverty is a really strong predictor of COVID, as expected. This map shows by county where the model showed a significant relationship between poverty and COVID. And if it's brown, it means the relationship was positive. So an increase in poverty leads to an increase in cases. And if it's blue, that lighter color, it means the opposite relationship. So an increase in poverty would actually lead to a decrease in COVID. This is particularly what we see, the relationship between poverty and COVID is particularly strong in the American West and in the borderlands in New Mexico and Texas. But there are other interesting small pockets to be aware of. The Upper Peninsula of Michigan, that's interesting. Georgia, almost all of it actually, and Central Carolina. This shows us that poverty does not affect all populations exactly the same. Black race, of course, is also an important predictor of COVID-19. By and large, the relationship is positive across the entire United States. Higher proportion of Black leads to higher proportions of COVID in those counties. I find their strong relationship in New England and Minnesota and Nebraska particularly stark, while there is very little relationship to speak of in the West. And finally, rurality is protective in some areas, most notably in the American Southwest and in the Dakotas, but is associated with an increased rate of COVID in Texas, Georgia, Florida, and Tennessee. I reflect back on the statement I made earlier about inequality and that it looks very different in rural and urban communities. But analyses like these make me think that inequalities in rural areas may also look very different across rural communities. What is it about the American West that might lead to lower rates of COVID, less density, higher rates of compliance with mask wearing or other public health measures? Why does the opposite relationship exist in rural Florida and Texas? We have so much more to learn. The COVID-19 pandemic has been a really unprecedented moment in our history. It requires us to take a step back and deeply examine the structural, social, and economic inequalities that both led to the emergence of COVID-19, but also exacerbated the risk among our most vulnerable populations. It lays bare the deep structural inequalities in our society and begs us to take action. I do not find it surprising that in the midst of this epidemic, when we were all safest quarantined in our homes, that so many of us chose to stand for Black Lives Matter, LGBTQ communities, and women's rights. The past 8 months has shown me that the realities of COVID are exceedingly complex. There is no one data point, no one statistic, no one map that's going to tell the whole story. Rather, it's a story of intersectionalities. It's a story of the intersection of race, class, gender, and geography that creates systems of discrimination and inequality. We are defined by multiple categorizations in our lives that affect our health and well-being. We need to attack these on all fronts. There's an excellent article recently published by Latoya Eves and Karen Falconer-Alhindi in Dialogues in Human Geography. It's called Intersectional Geographies of COVID-19. It asks geographers to embrace intersectionality. I'll leave you tonight with a quote from that article. The authors argue that intersectional analyses of the pandemic will generate better research, better scholarship, and better policies that attend to how a public health crisis shapes communities differently across scale and space. I would say to you, let us all do our part to generate better scholarship to help our communities fight in the fight against COVID-19. Thank you. And I guess I'll stop sharing. So hopefully, oh, I got little claps. Yay, thank you. I'm still learning all these cool Zoom things we can do. So Jace, I'll turn it over. You're the moderator, so I'll turn it over to you, but I'd be happy to engage in discussion and commentary on all of this. And I will say one thing, it's interesting.
Thank you so much, Dr. Root.
Oh, sorry, go ahead.
Oh, no, go ahead.
I was just gonna say, I feel like in my career, I've been a fairly broadly trained geographer. So I most of my research, if you go and look at my CV, is quantitative in nature, but I really appreciate the thinking and the theory that many of my other colleagues have done. And this concept of intersectionality, I know it comes from like the 1970s, but it has recently found an emergence, I think, in the popular press, popular literature, and in the scholarly circles. And when I started reading more about it, actually prior to reading Latoya Eves' great article, it really struck a chord in me because I've been working in social determinants of health for so long. And finally, I felt like somebody was speaking about it in a way that reflected the reality rather than trying to make buckets to put things in that separated out or siloed sort of the multiple characterizations that are going on. So I come full circle. And that's why I left with that piece, because COVID has reminded me even more that this concept of intersectionality is so important in the way we try to improve public health in our communities. So that's it. I just had to stand on my soapbox for one more second.
Definitely, the insight is quite useful in helping understand your framing. It's only 4:45, so we have plenty of time for questions. So again, feel free to come off mute or type in the chat, whatever you're comfortable with, questions. I can start with one to get things rolling then. Um, and then we can certainly get into other ones. You're showing all the excellent data and visualizations. So I've been curious. So have we sort of gotten to the point now where we have enough data, especially in these rural areas, about cases for being able to draw strong statistical conclusions? And maybe like if there were just sort of these random events, like a large party or something that brought a lot of cases, like is that still a confounding issue, or have we moved past it at this point?
The question of data, I feel like, has been the question of the moment for the COVID-19 pandemic. It was to me, it was quite clear when the pandemic first started to affect us that we did not have the data systems ready to collect the information we needed to be effective in monitoring and understanding the pandemic. And I still don't think we do. I mean, my work in Ohio has made me feel that even more so than I did when this all started. To me, what the challenge is, and I hate to bring up the concept of big data because I think it's overused, but I think the challenge actually is that there is no one thing that tells us everything we need to know about the course of COVID in our communities. So we can say, great, we know about case rates. Like we know how many cases of COVID occurred in this area or in this community. That's an important piece of information. But if you don't understand that piece of information within the context of how those data are being collected, if you don't interrogate that point, then actually that piece of information doesn't tell you anything. Because, I mean, President Trump said that if we stopped testing people, we wouldn't have COVID. And he's right, we would have it, we just wouldn't know about it. And so what that piece of data tells you is actually more of a reflection of testing strategies that are being done, which are unequally distributed across time and space. And so do we have all the data in some form? I feel like we may. But do we have the ability to look, and I'm going to use the word, at the intersectionality of these data to help us truly understand what's going on, to inform each other? No, I don't think we have that capability, or are we doing it particularly well?
Thank you. That other questions? Yeah, Craig.
Yeah, I was really struck by by the chart you showed that the data indicating that the primary drivers of the disease in rural areas were middle and upper income folks. I was wondering if you could talk a little bit more about that, or if you have any ideas why.
Yeah, between friends. So I don't know how many of you know much about Ohio. It is a very purple state, and it's purple only because our urban communities are extraordinarily blue, and are like really, really deep blue, like Craig's shirt color blue. And the rural communities are extraordinarily red, deeply, deeply red. And we have such a high population that it sort of balances out to purple at the end of the day, unlike a lot of states. So what we've actually been doing a survey called the Ohio COVID survey since April, where we ask people about their public health beliefs and their political beliefs, but also whether or not they wear a mask and things like that. And it is very clear that in the rural areas, there is a very politically conservative, upper middle class white population that does not want COVID to exist and aren't doing anything that we recommend that they do. And I think that ironically, this is one of those moments where the lower income underserved populations actually get it, right? They're worried about their health. Maybe it's because of their precarious unemployment and the fact that they're going to positions that put them at higher risk, but they get it, they understand, and are taking public health precautions. And that rural, wealthy white population is not. It is astounding. And when I first looked at that, I was like, oh my goodness, like here's a piece of data that actually supports a bunch of anecdotal stories that we get from our local health departments in Ohio. And I do find it, I mean, in the American discourse right now, right, this parallel between political conservatism and lack of adherence to public health guidelines, like, what's that about? Like, I'm not a political geographer. I just read about it in the New York Times, and I find it so incredibly problematic and odd, I guess. Like,
Well, if I could follow on just really quickly.
yeah.
By the way, I loved your talk. It was fantastic. But I was just wondering if that, I mean, you had, I think, one map that suggested that trend applies more broadly, right? Like beyond Ohio. You know, well, I guess maybe that's my question. Do you think that it does? I mean, clearly there's sort of like political camps, right? And if political orientation is driving some of those trends, then we might think that we'd see it more broadly in the United States. But yeah, anyway, I think that's my question.
Yeah, I mean, I think the Pew Research Center did a little bit of work in this area because they do, you know, one of their primary areas of expertise is political mapping the politics of the United States. And I do believe that they found something similar. Now, they didn't find quite the stark rural urban issue. And I think that's probably because they weren't looking for it, for one. They were just looking at the political question. But they did a really good survey that did show a concordance between political conservatism and non-adherence to public health recommendations around COVID. I think in Ohio, it's just seemed there is this rural urban divide because our cities are so blue that you can really see a strange dynamic, right? And it requires us to interrogate the data more, right? It requires us to dig into it more than just that cursory look at, oh, urban, rural, or black, white, or whatever.
Well, I'll admit that I had some similar suspicions, but obviously I didn't have access to the same data you've got. The other thing that strikes me about it is that given the profile, that another factor that might be contributing is just higher mobility, like, you know, motivation of the motivation to go and the ability to go, you know, obviously being two different things. Of, you know, if I'm going to ignore the rules saying that, you know, don't go see your family for major family events, okay, that's one thing, but also the ability to travel an hour or two.
Yeah, I mean, we've been monitoring mobility patterns in Ohio, and I know there's, you know, apps where you can go and look at Google mobility trends and all of that online, and they're really interesting. And I have yet to see a really strong pattern. I mean, there's sort of like large scale mobility, which does, you're right, it happens in our rural areas more. People just travel further to do stuff, right? The grocery store is not a mile away like it is for me. It's 25 miles away in Brown County, Ohio, right? And so there is that need to go further afield, right? And potentially, therefore, I guess, expose a larger geography of people if you happen to be sick. But the urban areas, the mobility is actually higher, right? Because it's small scale mobility. It's going downtown, or it's going, you know, to my kid's soccer game just north of the city. And in reality, in urban areas, we do more population mixing because we seem, I mean, at least that's what the Google Trends data show. It shows that we're actually moving more. It's just we're not moving as far.
Thank you. That's very helpful.
Yeah.
Also jump on, oh, sorry, it looks like maybe I'll just say this really, I moved back to Pennsylvania after 2 years living in Mississippi, and I found that in Mississippi, the rural urban mobility pattern was reversed in exactly the way that your data shows, right? So like in rural Mississippi, it's the rural poor who rarely go very far at all, but it's the rural wealthy folks who can travel much further to the grocery stores and all the things you're talking about. So I thought about that too, wondering how much it had to do with the differences in mobility patterns and how they break down socioeconomically in rural areas versus urban areas.
Yeah. So there's a comment in the chat, if people can read it, sort of reactions to the Rebecca Jones COVID data reporting in Florida, age, gender bias, sort of anti-geography, anti-data. I think I've been fortunate in Ohio. We haven't had an at the highest level, right? The Department of Health and whatnot, we haven't had much of an anti-data push. And in fact, I'm actually part of a project where we've built a surveillance tool for our school districts in the state to use to monitor the way basically COVID within their school district boundaries and among their students, because everybody's clamoring for this information. It's actually going statewide in the next couple of months. So I feel like at least my experience has been very pro data. I think that at the same time, there has been a desire to control information, right? I can't say that hasn't existed in the circles that I've been working with. Nothing like suppression of data or, oh no, we can't release that. I think most states have a dashboard. I feel very good that my dashboard in Ohio is reflective of what's going on, that nobody's suppressing data. I don't know that that's not true, or that's true in other places. I've watched Georgia's change a lot over the last couple of months, and I find it quite suspect, the changes that have happened on it. So I find it extraordinarily disheartening, of course. And I also have found it's not anti-geography, but there is a real desire to not release anything that's geographic in nature. I mean, you could argue privacy concerns. This is protected health information. I can understand that. But at this point, there's so many COVID cases. Like, who are you going to identify with like zip code level data out there or something like that? It was scary though. And my governor actually specifically talked to the data team about the Rebecca Jones situation and said that that was not something that he would ever do. Like he told us that, which was very proactive of him. But I have my suspicions about other states. I don't know if anybody else has any thoughts on that. I know it rocked our world, right? I think what actually bothered me the most was that she was attacked for being a geographer, right? That what did she know about COVID data? What did she know about data? She was a geographer. And that actually hit me hardest because it happens to me all the time. I'm a health geographer and I work in public health and epidemiology. And I'm attacked all the time. Oh, she's not a real epidemiologist. She doesn't really know what she's talking about. She doesn't have a degree in public health. And you know, we create these false dichotomies and then put people into buckets and then challenge their expertise and their knowledge. And that actually is what bothered me the most. I'm sure other geographers have identified with this at some point in their lives about what are you doing in this conversation? You're just a geographer. Lots of nods. It's sad. It's true. We're the best trained people to look at this epidemic, folks. Don't let anybody tell you otherwise. We understand the extent and the breadth and all of the intricacies of what's going on today in a way that most disciplines never will.
That's a great way to end on a high note, I suppose, and for an AAG meeting.
Yeah.
We can go another minute or two if anyone else has any last questions or comments.
Yes, please.
So did you say you were growing up, was it daddy or your uncle? And was that in Ohio? Who was that who had done some epidemiology?
Oh, so that was my grandfather, actually. His name was Harry Fillmore Dowling. And he actually he did some of the first research on penicillin. And he was originally from Virginia. But most of his career was spent in Illinois at the University of Chicago. University of Illinois. He was chair of medicine there for a long time. But he retired actually to Washington, D.C. area. And that's where I knew him growing up, is I would go visit him in Washington, D.C. And he did love to walk. That man, he would walk for miles every day until he was like 90. But he wrote a book actually on emerging infectious diseases that I still come upon as a reference material in articles that I read. And of course, when I was 7 years old, I had no idea. And he passed away when I was probably about 13. And I never really understood until like 5 years ago what a big personality my grandfather was, and that I was kind of doing some of the same things that he'd done in his career.
we'll be curious to know whether back then they connected those overlaps, those intersecting identities with what they were observing. And secondly, do you have any answer for that miracle or that puzzle that's Africa today?
Oh gosh, I wish I did. I think I would. I've actually spent quite a bit of time in Zimbabwe and I have some partners in South Africa and Johannesburg. And it is an incredible meeting of cultures and people and places in Africa in a way that I don't think we see in many places around the world. And it creates complex intersectionalities at the same time as being like an incredibly rich place. And it's not Africa, right? It's tons of countries and cultures and people. And it's so, you know, I hate it when people talk about, you know, try to put a whole continent together without understanding the diversity of the peoples and the places there. I think it's interesting. My grandfather actually wrote a book called The City Hospital, which was about his time working in essentially one of the city hospitals in Chicago. And he never explicitly talks about intersectionalities or sort of the complexities of different groups, but you read it and you can see that he did understand it, right? Because he did a lot of patient care. And so you could see that he understood that these city hospitals were where all of these diverse people came together, and what a challenge it was to serve all of those communities in the way that they needed to be served to provide the best patient care. I mean, he has a very different view because he was truly a medical doctor and did patient care. And I've never done that in my career. But I could see that he did get it because he worked with a person. And yet I don't think he had the language, probably, or even the training that we have now to be able to express that complexity and that intersectionality. But it's existed for a long time, I think.
Thank you.
Thank you. Thank you for joining us.
Great. Thank you so much. Maybe have like a virtual applause for Keynote, or use our reaction.
There we go. Dorothy gave me the little hands. Thank you. Well, thank you, everybody. I know it's a Friday at 5 p.m., so I appreciate you spending the time with us. And I'm so proud of you in your regional AAG meeting of going forward and doing it, so that we can share our knowledge and our expertise even in a time when it's so hard to get together and share those. So thank you so much, everybody.
Thanks again. You've given us so much to ruminate on, and thank you for taking time out of the busy research schedule to speak with us. And
Absolutely.
Just a quick reminder for those of us who have sessions coming up, let's go into the Zoom room. The session starts at 5:10. And then we have the Geography Bowl, and we'll be back at it tomorrow morning. Thanks again, everyone, for joining, and to Dr. Root for that really fascinating talk.
Great. Thanks all.